For more than 15 years, she has been specializing in access to medicines policy and advocacy. Originally a trained journalist, she also has experience as a policy specialist for the MSF Access Campaign and as a political advisor at the European Parliament. And over to you, Helle.
Thank you, Rohit. Welcome everyone to today's event. Before we get started, I just wanted to mention that this year ReAct is actually turning 15 years, and these issues of antibiotic innovation, access, stewardship have really been central to our work since the very beginning. And so this report and this event therefore feels very appropriate as an appropriate way to mark this anniversary. Oh, let me see, how does this work again? Voila. So, as you know, 2 weeks ago, we released this new report. Now, some of you might think that the last thing that this space needs is another report. So I thought I'd start this presentation by going through why we believe that this report is needed. And so first of all, this is really an attempt to broaden the global debate from one that's so far been very narrowly focusing on push and pull incentives to one that is really about achieving sustainable access for all. And we also want to direct it at those that we believe sit with the primary responsibility to act, governments. Secondly, we want to reframe the narrative antibiotic resistance from a medical and One Health challenge to one that really reflects global inequality and a lack of global solidarity and pursues sustainable access for all. We want to revive discussions on how to best address antibiotic resistance, in particular against the ongoing, the backdrop of the ongoing COVID-19 pandemic, and political discussions that are happening right now to build back better afterwards and create possibly a pandemic treaty. And so finally, we also want to make the case for multilateral action and solutions as the most appropriate answer to global problems such as antibiotic resistance. So we're coming off more than 30 years of failure and standstill in developing new antibiotics. And meanwhile, antibiotic resistance to all of our existing antibiotics continues to develop across the world. And to address this problem, it's clear that new antibiotics must be developed. But this does require government to start doing things differently, and for them to start taking an end-to-end approach that spans all the way from discovery and all the way down to patient access. And so we believe that a new approach should be designed to achieve 3 end goals: that the right antibiotic is affordable and accessible to everyone in need, that antibiotics are managed in a way that preserves their therapeutic effectiveness and thereby slows down the development of resistance, and that antibiotic production from a robust, reliable, and environmentally sound supply chain is able to satisfy global demand. And we believe that these actions or these end goals should guide governments in their interventions in order to achieve sustainable access to effective antibiotics for everyone. And towards this end, the report identifies 5 key challenges that should be addressed and resolved. Challenge 1, as you can see here, has to do with priority setting that address the most significant and unmet global health needs. Antibiotic resistance, antibiotic R&D and funding for it is largely a national endeavor. And this means that R&D funding is often shaped by national interests and medical priorities of the countries that are funding it. And that results in a patchwork R&D landscape where pathogens that are prevalent in low middle income countries are left under prioritized, and pathogens actually of biggest global concern aren't sufficiently addressed. So currently, if we're looking at the most recent pipeline analysis from the WHO, just half of the compounds in clinical development are actually targeting the pathogens that are listed on the WHO's global priority pathogens list. And very few of the compounds that are in clinical development are considered being innovative. So challenge number 2, overcoming the barriers in the early discovery and research phases. So this is related to the issue of lack of innovation. And a problem that is really often quite overlooked is that big unresolved scientific challenges continue to hamper R&D of new antibiotics. Traditionally, antibacterial drugs have been estimated to have a 10-fold lower yield in the discovery stage compared to all other drug classes. And many of the scientific challenges leading to these higher failure rates, such as penetration, efflux, managing toxicity, they all remain unresolved. Furthermore, the withdrawal by most of the multinational pharmaceutical companies from the antibacterial space over the last 20 years has also led to shrinking finance and expertise disappearing from the field. And so today, small biotech companies and academics have filled some of the gap of the early stages of clinical development, but they often don't have the expertise in later stages of clinical development. And so even if these smaller companies and academics wanted to expand into clinical phases of R&D, crossing the so-called valley of death, that means moving a compound from basic into clinical research, is really difficult because public funding for such translational research is limited, and securing venture capital is almost impossible unless there is an indication that a larger company will eventually acquire the compound. So challenge 3, financing late-stage clinical R&D without relying on price and sales volumes of the end product. So put quite simply, the traditional market-based financing model from pharmaceutical R&D relies on charging high prices and pursuing high sales volumes in profitable markets until the patent or other monopolies expire. However, if we want to achieve sustainable access to effective antibiotics, misaligned incentives to oversell need to be removed, and access and stewardship shouldn't be enforced through prices. And this is why delinkage really has emerged as a promising model, because it is a model that can pay for R&D costs and remove the need to charge high prices and maximize or the maximizing of sales volumes, because public funds are used to pay upfront instead of paying for the R&D once the drug is on the market. And challenge 4, ensuring sustainable production, quality, procurement, and registration of novel antibiotics. So once a novel antibiotic has been brought through clinical development, there are still several problems with the current approach to production, registration, and supply of antibiotics. And all of these needs to be addressed in order to avoid shortages, to improve poor production practices, to address problems with substandard and low quality drugs, and also to improve global registration of antibiotics. However, our current system and the tools that we have available in that system to sort of control and manage a new antibiotic aren't really fit to address this comprehensively. So patents, for example, are just time-limited means of control. You know, after 20 years, they expire. What do we do then? How do we control all these elements of production, registration, etc. Afterwards? Same thing goes for national level action. Of course, it can take us some of the way, but by nature, by being national actions, they are just sort of pieces in a larger puzzle that can only go some of the way, right? So we need a different way and different means to address these issues that go beyond sort of the durability and fragmentation constraints that we are seeing of the current system that we have right now. So challenge 5, ensuring sustainable access to new antibiotics in countries. So how new drugs and how new antibiotics are introduced into countries and health systems in a way where our current practices of overuse, misuse, massive problems with lack of access to essential drugs isn't repeated. That's really a major challenge that we believe hasn't received enough attention so far. Closing the holes in the bucket you see here means that, you know, if we're not doing that, investments, resources, and time that are spent in developing new drugs will likely be in vain. Because if resistance develops too fast, if we introduce them into systems that aren't able to preserve them, what's the whole point of it, right? So this is probably one of the strongest arguments of why we need to broaden the discussion beyond one that just focuses on incentives and really start talking about how are we long-term planning to manage these drugs in a far better way. Okay, so moving over towards the recommendations. So most of the problems that we've outlined in the 5 challenges in the report are really transnational and even global problems in their nature. And we believe that addressing these will be much more successful if governments can cooperate, if they can work together through a system of rules-based global governance to introduce common rules and priorities and focus on what is needed for global public health. That's not to say, that's not the same as saying that national action isn't needed, but we do believe that a commonly sort of defined playbook is needed to ensure that individual action by governments can become much more coordinated and as a result of that become more effective. So more specifically, we recommend that governments should come together to adopt an ambition to ensure sustainable access to effective antibiotics for all and steer public action with much more intent. We recommend to establish a global R&D coordination entity that has stable and sufficient funding and an appropriate mandate and expertise available to effectively coordinate antibiotic R&D. And this could take place, for example, under the WHO. We recommend that governments should increase early stage funding for antibiotic R&D, and in doing so, also work to increase transparency of R&D costs and for the agreements that are drawn up along the way throughout clinical, preclinical and clinical development. Finally, we believe that governments should come together to establish a new global R&D financing model that really can deliver affordable antibiotics and that by design removes misaligned incentives to oversell. And we believe that this is the definition of what should be understood by full delinkage. And so, final couple of recommendations here. Reinvigorate negotiation of rules-based governance. We've already seen governments engaging in this at the WHO. It's been dormant for some years, but now is really the time to reinvigorate those efforts. And we believe that such a mechanism or such a framework of common rules should also include a mechanism for pooled or centralized procurement and also a mechanism for global pooling of intellectual property and patents. We also recommend that an international task force that focuses on introduction of new antibiotics into countries established with broad country representation to ensure that we have all perspectives reflected in these discussions, and that such a task force ensures that input is really sought widely, also from civil society and professional societies, of course. And finally, implementing all of these recommendations will certainly help, I think, close many of the holes in the bucket that I showed before. But at the end of the day, health system strengthening in low and middle income countries will be necessary to go all the way. And we can't do that without also providing financing options for LMICs in support of doing this. And so with that, I will end and we can go over to the discussion. So I'll hand over to you, Rohit.
Thank you, Helle, for your really clear presentation of the 5 challenges and some of the recommendations included in the report. So as we've already mentioned, we'll now examine each of these challenges in depth by turning to our 5 panelists, each of whom will discuss one challenge for 7 minutes each. As a reminder, please feel free to, again, to submit questions as you listen to these interventions, as well as submitting any comments you might have or feedback in the chat. So our first panelist will be Dr. Monica Balasegara. Monica is a trained medical doctor and the executive director of the Global Antibiotic Research and Development Partnership, or GARDP, a not-for-profit organization developing new treatments for drug-resistant infections. His experience spans clinical and public health practice in infectious diseases and international work on health policy and access to medicines. He also has substantial experience in conducting and overseeing clinical trials and drug development projects. Dr. Balasegara will provide his views on challenge number 1, or setting priorities that address the most significant and unmet global health needs. Monica, over to you.
Thank you very much, Rohit, and it's really a pleasure to be here today. And first of all, I'd really like to thank ReAct for an excellent report. I think it's been long overdue in terms of the need to highlight access and really the gaps we have around access. And indeed, I do share the sentiment. There has been a lot of focus around research and development, around incentives, and to a lesser degree, some of the other issues that are important in antimicrobial resistance, like better surveillance and infection prevention control. But I think access has been pretty much largely absent in these discussions. And indeed, I also share the sentiment that I think COVID-19 and the response to the pandemic has really brought this out as an issue. We've seen tremendous success in developing new technologies, but I think where we've really run into much more challenges is access, indeed equitable access. And so I think this report really covers several aspects related to equitable access. And I think what is commendable is that it takes an end-to-end approach. Now, typically having worked in global health for 20 years, one of the problems I always see is that is a tendency to silo access and research and development, or rather silo research and development from access. And this is actually quite strange. In some areas like HIV, this has changed. And importantly, in the private sector, one simply doesn't do that. I've often seen private sector entities really think about how they approach marketing and access well before licensing. So in the global health world, our tendency to silo one from the other is, I think, quite strange, and I think has really led to some of the problems that we typically see when we get to kind of downstream issues. Now, where does priority setting fit into all of this? Well, I think setting priorities is fundamental on many levels, particularly in research and development. It's needed because to ensure appropriate direction of long-term research and development projects, you need to understand where you want to go right from the outset. And so in that sense, particularly in R&D, one has to be clear about priority setting. It's obviously essential for good use of public money. And I think it's actually going to be required, not just for pull incentives, but absolutely required for pull incentives. And indeed, I think if pull incentives are misdirected, it may actually undermine faith in such incentives and undermine the sustainability and future of such incentives. So I think it's in everybody's interest that we get the priority setting right if we want to see innovative incentives, both push and pull, enter the scene and in this space. I do, however, think priorities need to be much more nuanced, and they need to be updated on a regular basis. I'm not saying every 6 months, but every few years, one does need to review where one is. And things change, and we see that even in this kind of rapidly evolving pandemic. I also think priorities need to reflect geographical and population diversity. What we may need in some parts of the world may be very different in other parts of the world. What we may need for very young populations may be different for older populations. And I think much of that nuance is just simply absent when we talk about priority setting in antimicrobial resistance. And as I mentioned, priorities will change over space, geographical space, and over time. I do think at the moment we run the risk of a situation of where we set priorities according to where resources are and where incentives are being put on the table. And that's not surprising. Governments who put money on the table have to set priorities. But I think if this is not taken at a global level, there's a risk of skewing this. And so we may get a situation where, and we are going into a situation where we're setting priorities very much with a perspective of a few high-income countries that are putting a lot of money on the table, and we need to give them credit for that, but where we may see a lower disease burden in that sense. But that may have a consequence of skewing the pipeline towards those needs. And it may mean that global health needs will be largely unmet. Now, I think that's risky for everybody because, as we know, things change over time. And actually, what may be a priority today in a high-income country may be different tomorrow. And we may see that what is affecting low middle-income countries today may become a bigger problem in high-income countries. So it is important that I think we take a global perspective as well as a country and national perspective. Now, I think priority setting has started in AMR, but in my opinion, I think this has stalled a little bit. I think WHO did a very good job getting the priority pathogen list off, but I think one has largely gone into the priority pathogen list and we haven't really gone beyond that. To me, the priority pathogen list is an important start. I think it's been incredibly useful and actually has shown the value of priority setting, but I think it remains a bit too superficial and a bit too two-dimensional. And I think the challenge for me is obviously things that I've mentioned. We need to look at populations and different populations, low middle income countries and so on. Now, the challenge for that is getting good data and estimating disease burden. And I recognize that because of this gap, it is and still remains a challenge to set priorities. Now, in GARD-P back in 2016, we actually developed our own program priorities based on a matrix where we looked at pathogens, populations, and diseases indications that are disproportionately affected by AMI. And even though there was a data gap, I think that has really helped us to set grounded priorities. For instance, it's why we focused on newborns and children. And one publication cited shows that estimates 200,000 to 300,000 deaths a year in newborns alone. And if you just think about what the global estimate of deaths from AMI is, that's a pretty big chunk in one population. And yet, so little resources go into neonatal drug development. And GARD-P and partners are one of the few, there's a few companies involved as well, but one of the few that are really involved in this space. So something seems to be wrong here. And actually, this has also been pointed out by others. Brad Spellberg and colleagues published a paper in 2019, and they actually proposed what they called the dartboard to target incentives. And here it was really talking about a proposed multi-stakeholder group that would review, set, and update priorities based on pathogens causing serious infections, and that the list would be dynamic. Now, this was very US focused, but I think the sentiments expressed there actually are similar to some of the sentiments that you've expressed in your report, although I do think that this needs to be done with a global perspective. And I do think we need to go beyond just the pathogens, because as a physician, at the end of the day, I've always treated people rather than bugs. And people come in all shapes and sizes with many different types of presentations and problems. And that's what we need to direct research and development towards as well. Now, I would like to end by saying another major challenge we have related to evidence generation, related to priority setting, is evidence generation. And this is required because ultimately drug candidates or vaccine candidates or diagnostics need to demonstrate that they meet priorities. And you can only demonstrate that you meet set priorities through evidence and data. And I think the current regulatory pathways we have, for instance, in drug development, don't adequately allow for this. I'm not saying that we should change that, but I'm saying that we do therefore need to generate more evidence beyond the regulatory pathway to show that we can meet priorities. And I think your report discusses the plasmamycin case that actually, in a way, is an example of that. And to me, this evidence generation space that really starts in late stage clinical development and goes beyond registration is the real value of death. And this is where we may experience what Brad Spellberg called pipeline collapse. And I actually do think this is where candidates are going to fail. Even many good candidates may fail. And actually, in a recent report published by the EU JAMRAI that came out just at the end of last month, authored by Christine Adald and colleagues, one of the things that they noted there was a certain skepticism by countries they interviewed on the public health values of many new drugs. In fact, some of those countries were actually asking for superiority trials, at least for further evidence. And this is pretty much what I'm talking about. I actually share that sentiment and understand how countries feel. Now, if countries think like that, how do you think they're going to think about setting incentives? So I certainly think it's in everybody's interest. If you want to see incentives and so on, you do need to talk about not just priority setting, but evidence generation.
So Monica,
I also think,
so we can,
yeah.
I apologize just for wrapping up so we can, and
sure,
we can come back to some of this, especially in the discussion.
Yeah, sorry, I'm nearly done. Yeah, and so I think also evidence generation is also absolutely critical for guidelines and stewardship. Now, I think this hasn't been entirely covered in this report, but I do want to put this down as an additional piece, because I think it's something that is not well understood by policymakers, and I have to say even sometimes with colleagues that I work with, including my great colleagues in WHO. This is a conversation that we need to have in more detail. So I'll end there. Thank you very much. And I'm sorry if I've gone a bit over time. Happy to take questions later.
Thank you so much, Monica. And I think we should definitely come back to the questions you have raised, including since we have somebody from the WHO to perhaps respond to some of the challenges you've highlighted and some of the gaps. So we will now move on to, and I'm going to apologize because I'm going to make a mess of the name, Dr. Ursula Gurensbacher. I apologize if I have messed that up. Who is an expert in antibacterial drug research, discovering development strategies and policies based on clinical and public health needs. She has been working in antibacterial drug research and development for more than 30 years and worked on the priority pathogen list for the WHO clinical and preclinical pipeline analysis, and the WHO target product profiles that are used to inform research and development. Dr. Gurensbacher will speak about the second challenge, or overcoming barriers in the early discovery and research phase. Ursula, thank you.
Thank you, Rohit. So I cannot agree more with what Monica just said, but I'm adding a few more thoughts about the very beginning, the antibiotic drug discovery. So if we are, in recent years, we mainly heard about pull incentives, but if we are not talking about drug discovery, we will not have much to pull. And I think that will be a crisis. It is already a crisis, but will be more crisis in the next years. So where is drug discovery happening? It's mainly in academic institutions by highly motivated and enthusiastic researchers. They are driven by contributing to social value. These could be also publicly funded institutions, and then finally university spin-outs. So that's where antibiotic drug discovery happens. These institutions have a lot of challenges and barriers. When I talk with them, they tell me they expect us to mimic a pharma company, but we are not a pharma company. We are a university or a small company, an SME. So beyond the limited financial resources that they all have, one of the main challenges is a very narrow expertise. So they are great experts in their small field of research. It's very fragmented, and they usually have the pressure to publish. So that's what follows from that is that research is often not continued after publication because they need to go to the next area to publish the next paper. This means that this research is often not translating to a viable drug discovery project. In general, there's no or little drug R&D knowledge and experience. So they don't know what's really happening after their studies, how to continue. And they don't, for sure, usually know what's ahead of them, what it means to have an R&D project. We heard already today about valley of death, and I think there are more than one valley of death. So in early drug discovery, we have a very pronounced valley of death that comes after you have found a hit, where you have to validate this hit and where you have to show that it works in principle. That means you need animal facilities, and that can be a really pronounced problem. And you need to optimize your lead if you're coming to this stage. And that usually means a lot of medicinal chemists. This is hard to find at universities. In general, there is no future for young researchers in this field. So most of them stay as long as there's funding for a certain project and then they're leaving. So I'm not talking now about all the scientific challenges that we see in gram-negative bacteria. So lots of barriers and challenges, but there are also concepts of how to overcome these barriers. It's, for instance, providing R&D support plus training plus project delivery by, for instance, public institutions. That means young people could deliver their project, their PhD thesis or whatever, get training at the same time and have the R&D support, so the infrastructure. One example was in the last years, the enable infrastructure, where what could serve as a basis for such an institution. We need urgently a hub for accessible antibiotic discovery knowledge. And what I also heard very commonly when I interviewed researchers was, we don't know if our project has value. It's our baby. We don't want to let it go. And we need an advisory board, an independent advisory board that evaluates and validates our discovery project. And then the last point, of course, is funding, grants and funding strategies. And besides the need for funding basic research, of course, that has to happen. And I don't want to take any money from universities and their basic research, but we also need targeted drug discovery funding strategies. And now to close the circle to access, if these funding agencies don't think about access and the need also in low and middle income countries, then they would mainly fund strategies that are really not usable by these countries. So for instance, if you need a very sophisticated healthcare infrastructure to even use this product, then finally, then it will not be of much use in these countries. So I don't think that phage therapy or very sophisticated other therapies where you need a diagnostic and fast diagnostic everywhere, that these would be accessible worldwide. So thinking about funding strategies already determines what we'll get afterwards. And if we only get pathogen directed therapies, then that will not be enough for the future. So these were a few thoughts. It's a very interesting field and discovery is very important. It determines what we will see in 10, 15 years.
Thank you very much, Ursula. We will now switch to the third challenge, or financing late-stage clinical research and development without relying on price and sales revenue of the end product. Speaking on this topic will be Dr. Viviana Munoz. Viviana is the coordinator for the Health, Intellectual Property, and Biodiversity Program at the South Center, which is an intergovernmental think tank of low-income countries that currently has 54 members. She is also a multidisciplinary policy expert in the area of public health, intellectual property, and biodiversity, with 15 years of international experience. Viviana.
Thanks, Rohit. And first of all, congratulations to ReAct, especially Hele, Anna, Rohit, of course, Otto, and everyone else for this great report and generally the very good work you do. So I think I'll just start more broadly framing that the challenge in the R&D area really is, how do we ensure that we have a full ecosystem that works in the sense that it can both incentivize true innovation while promoting equitable access. So when we're looking at the antibiotic space, we're really talking about the fact that we have a broken system for antibiotics innovation. So a healthy innovation ecosystem involves many diversity of stakeholders in different roles. Now, as Helen mentioned in the highlights of the report, I agree that the government has a leading role to play in the antibiotic space, as in other disease areas and in the context of pandemics, where market-based R&D model does not deliver. And that's why here it's so important that governments have the main responsibility, because if we relied on the dominant market-based model of pharmaceutical R&D, we would need minimal government intervention. But we know that in this space, as in some others we've seen, it does not work. So government must take the lead in close consultation with all the key stakeholders that can operate in this R&D system. So I also agree with what's been said about the need for more inclusiveness in the design of solutions, not only to come at the end, extending the invitation to join initiatives that are conceived already, thought out for particular problems, and led in particular by a few group of countries or stakeholders. I also agree with what Monica has mentioned, that priority setting is really key in a broader sense. We need to look at the context, what are the needs, and also at the variety of the types of drug-resistant infections, rather than only let ourselves be driven by where the resources may be. So I think the challenge 3 in the report, which is as titled Financing Late-Stage Clinical R&D Without Relying on Price and Sale Revenues of the End Product, as with other challenges, is really part of this broader challenge of building an R&D ecosystem that works, as mentioned, with incentives for true innovation and promoting equitable access. So I really like the problem framing in terms of that we have a global crisis, so critically, this is a global issue, and that the aim is really to achieve sustainable access for all. So linking innovation with the access issues and promoting equity. So we need new antibiotics to replace the old ones that are not working anymore because of resistance. But innovation per se is not the goal. Access is the end goal. So we have a system of pharmaceutical research and development where the incentive structures can exacerbate global health inequities. And this has been rightly mentioned in the report. We see this with the COVID-19 pandemic. We might have some richer countries getting access first, middle-income countries having the resources drained to get access, with poor countries then depending on charity. So as a society, we should really be ashamed that this is taking place. And in the antibiotic space, we have this opportunity, as we sort of have a blank page of where we are right now in terms of innovation, to really take some lessons and do things better. So in many discussions on pharmaceutical innovation more broadly, we hear the argument that you can't have access if you don't have innovation first, and we turn in circles. But in the space of antibiotics, again, little innovation is happening. We don't really see true new class of antibiotics coming up. And this means that we also don't have strong alternatives to replace antibiotic treatment so far. So we do need to be pragmatic, of course, but we also need to be bold and more ambitious. And it's very clear that the problem is highly complex, but that doesn't mean we should shy away from it and focus on short-term gains versus what should be the long-term approach of what we're trying to achieve. So I think we focus too much on sort of what are the short-term gains, coming up with what could be perhaps the more simple solutions, but these are partial and potentially ineffective, or even might not lead us to the right approach. So again, just taking from what we've learning from the COVID-19 situation with vaccine inequity is, yes, we've seen rapid science scale up, and that's a part of what's been very effective. But we've also seen, as Dr. Tedros from WHO mentioned, a catastrophic moral failure in terms of vaccine inequity. So I think just to mention it, for example, participating in the R&D working group at the UN Interagency Coordination Group on Antimicrobial Resistance, there is a lot of reluctance to think out of the box, out of what might not be considered, usual practice, and come up also with some practical ideas to put forward some more, as is mentioned, end-to-end approach solutions. So now coming just a bit to again, why it's important to have this ideal in mind. It's because where is it that we want to arrive to? We could have the potential to develop and treat antibiotics as global public goods, We clearly know that we want to conserve these, that they're important for everyone around the world. So making sure that they're equitable to all countries and not only those who bid the highest for access. And that we need to figure out a global system to manage them carefully, both in terms of ensuring the correct supply, but also how do we manage the demand with adequate stewardship as well. So it would be a real huge global policy failure if we embark in promoting antibiotic innovation without thinking about how will we define when and who gets access to new antibiotics. So again, just to mention the point that this is really an opportunity if we agree to correctly frame the real challenge. So at the risk of oversimplifying the issues, there's perhaps two contrary conceptualizations of the problem. And one is the focus that we need to bring back pharma. So that the main problem stems from the low return on investment that pharmaceutical sector would see in the antibiotic space, where of course profitability is the main driving factors. So that the attempt should be for government to basically pay pharma to bring antibiotics to the market. That is to take larger burden and of course, independent of the discovery challenge as has been addressed previously. So in this sort of thinking, the governments would continue to provide strong patent protection over other government granted exclusivities and to enable limiting generic competition, which we also don't want to have increased volumes and low prices for increased sales of antibiotics. So here we would still have an issue again about we're not changing substantially some of the systemic issues we have in the R&D system. And so here again, so we have a pharma-led model, profit-driven, but we have substantial public financing coming in order to sort of replace that in existing market for profits. But the other way to look at it, and I think this is where the report is providing, again, attention to that there is another way of thinking about it, is to really tackle the challenge with a new model of research and development that's public health driven, so really setting priorities from where are the needs, providing adequate incentives for all involved, and that's really critical. If we don't have the right incentives, of course, nothing will happen. So clearly that is also at the root of what needs to be done. But also how can we reduce costs? How can we be more effective and efficient? And this is also taking account the needs of the diversity of actors. So as we all know, it's not just the large pharmaceutical companies that we're discussing why they're not in the sector. We have these specialist small companies, academic groups, we have government agencies, we have philanthropy on board. So this is a much larger ecosystem we need to look at. So how can we really stem up true collaboration also across countries and across regions? So we need to, of course, rely on how can public sector through financing allow to provide private sector parties to recoup costs of their collaboration and of their private investments, but ensuring that these are modest profits and that are not dependent on sales level or high prices. Critical to the system, again, is how do we increase the sharing of data of results, particularly attrition in early research and clinical trials, transparency of the costs that are involved so we know how much is fair to pay, transparency on public investment that's put into the ecosystem. So where are these values? We see this is usually not the case that it is provided. And also sharing technology and pre-existing IP. So how do we manage IP where it exists? Can we think of better ways for incentive systems? Considering the misaligned also potential incentives that are created from the reliance on patents and other monopoly rights.
I apologize for jumping in, Viviana, just if you can wrap up. I know you have an enormous topic, but we'll try to come back to some of this also in the discussion.
Right, so I'm coming to my last point then, is that I agree as with the report that we need to come back to the essence of what is the total linkage model. That's more here in line with this concept I was mentioning. So no direct sales or high prices that would hinder equitable access, not this reliance on the IP system, but really look at what could be push and pull mechanisms as tools to tackle the challenges, but not just for innovation itself, but for access that is well managed. So I think, again, in terms of where governments stand is we really need to see, will the governments have the courage to take on this necessary role that we need? If we agree on this challenge, we need to then have all governments involved in shaping this response with the common objective of equity. And we need then to all the stakeholders to have this collective vision We need pharma that can participate, but not to take over the discussion or cling to the old business models that have shown to be unworkable for antibiotic innovation. Thank you.
Thank you so much, and for covering such a wide area of discussion. So it's fantastic. Just as a reminder, we're receiving questions, so please add questions if you have them. If you have comments, I noticed one comment come in. Please put that in the chat so the rest of the audience can also take a look at the comments that people have in some of the materials they want to share. So we will now move on to Mr. Peter Byron, or Doctor, who is a trained lawyer and unit head for Access and Innovation at the AMR Global Coordination Department at the WHO in Geneva. He is responsible for issues related to public health, trade, and intellectual property, and leads a team working on antimicrobial resistance. He was also responsible for drafting the global framework for development and stewardship to combat AMR. Peter will provide the WHO's perspective on ensuring sustainable production, quality, procurement, and registration of novel antibiotics. Over to you, Peter.
Thank you, Rohit, and thank you to ReAct for inviting me. It's really a great pleasure to be here. It's a very interesting report. Helle, you said we don't need more reports. I disagree. I think this one is really, from time to time, there needs to be something which actually revisits the issue, sees where we made progress and where we actually have to readjust. And I would like to start with what Monica said on the priority setting, because that is maybe one area we can actually solve. I totally agree with what you said. I mean, the priority pathogens list was a great first step, but it has issues. And Ursula mentioned it. There are many companies that are now focusing actually on pathogen-specific treatments, which require very specific diagnostics we may not even have, or that may not be used actually in very many low and middle income countries. So I do think that the next iteration of the priority pathogens list, we need to take into account what Monica said. We have to focus not only on pathogens, but also on populations and on syndromes, and provide actually better guidance to the R&D sector and what do we want them to develop. And that can be also small priorities. At the moment, we are always looking at the new class of antibiotics. Maybe they're also easier quick wins for specific, as Monica said, for specific populations in specific regions. And that is also something that I think where it's different from HIV, where we have WHO global guidelines, where we have the first line treatment it's the same all over the world. That's not going to work actually for many of the bacterial infections, where we do have to take into account regional differences in resistance levels. And that is where we as WHO, I think we need to do much more. And I think that's feasible. It's a feasible investment. And probably it's going to be a good contribution to the solution. Having said that, yes, 7 minutes for production, quality, procurement, registration, it's a challenge. I want to say a few words, on production and procurement, because to me, this is very much linked. Because, how goods in general are produced depends on what is the buyer actually buying. And if the buyers change what they buy, the producers are going to adjust to what the buyer wants. And at the moment, actually, the hospitals in Europe, they want to buy very cheap antibiotics, and they don't care about all the rest, as long as they meet GMP standards. And that is why we have the production facilities we have, and that's why we have actually the costs were minimized throughout the supply chain, putting pressure on the supply chain, putting pressure on the environment in countries like China and India. And in particular in the generic market, it is because the pricing pressure is enormous. So we have a 3-year project that is financed by the European Commission for France. So we are assisting France to mitigate shortages of essential antibiotics. And it's a project where we really want to come up with sustainable solutions. And I think, Helle, you said we need to work with governments. I would to say we need to work with buyers as well. And the buyers are often not the governments in Europe. So in the French market, the generic antibiotics that are most often in shortages, the parenteral products used in hospitals, are bought by hospitals. Switzerland the same, Germany the same. Other countries have different models, of course. this differs from one country to the other. But so we really want to figure out at the moment, speaking with those who do the procurement for the hospitals, what are the criteria they use to select actually a vendor? And are there ways to actually have a more sustainable production by paying more for companies who can prove that they are actually having an environmental sound supply chain, and they have actually taken measures to ensure that they can ensure a continuous supply of these antibiotics, and they have actually a stockpile in case when they have problems. And then, of course, it means that the buyer has to pay a premium, because they may actually have a company that is investing more in a more resilient supply chain and in a more environmental friendly production. And that is something that you can, where I do believe you have to actually work with the buyers, because what we see when we speak with governments is they say, yeah, we have difficulties regulating it, because I mean, as WHO, we're exploring whether GMP is a good entry point for environmental standards for antibiotic production. But that if we can change the way that the procurement is done, we can do what UNITAID would call market shaping. And we know that it's possible. It was done in TB and HIV and malaria. The problem is only that we need to actually get the hospitals to have a sufficient critical mass to impact the market. If you look what Civica Rex is doing, which is the association, the company that was created by generic companies, by hospitals in the US, which represent a huge number of hospital beds in the US. They move from procurement to tendering to actually do contract manufacturing. They have supply contracts, contract manufacturing with European suppliers of injectable antibiotics over a number of years, and tell them, well, you're going to produce this amount of drugs every year for us, and we buy them. So it's a different way of actually purchasing the commodities, which makes it more sustainable also for the companies, because they have a better horizon on how much product they are going to sell to whom. So I think that is one area I think where we have not paid enough attention to on how we can influence the current situation. Of course, and then, I mean, quality and registration. As WHO, we are surveying the quality of antibiotics, and we do know, and you quoted in the report from our global surveillance system, quality of antibiotics is in particular a big problem. And that is a long haul. It's a long fight. And this is something where we need to work with regulatory authorities in the countries, strengthening them, tracking the products, taking them out of the market. That is unfortunately not only a case for antibiotics, but for all kinds of medical products. And that is something where we probably need to strengthen the efforts overall to actually fight this problem, not only for antibiotics, but for all the products. And registration, yes, the bandwidth of the small companies, as Ursula said, I mean, these companies, they just have not the capacities to do worldwide registration. Let's say something positive about the patent system for once. If you go to WIPO, you can actually file a patent application for all the countries that belong to WIPO. It's much easier to file, actually, you have to follow up then on a national level, but you do have an authority where you can file a patent application, you tick the boxes for all the countries, and that's where I want to file my patent. Why don't we have this for drugs? It's something which I think where we failed to deliver a system which makes it easy for the companies to go for registration in all these countries. And we can do this with regional authorities. Africa, they have set up the African Regional Medical Authority. That is a good way of doing these things. And if that would work, it would bring us, I think, a way forward.
I apologize, Peter. I just wanted, and I know, especially when we get talking on the patent system, that's definitely a good time to jump in. But I'm kidding. If you can wrap up, we'll also again try to come back to some of these in the discussion we have. I apologize.
That was actually my last point, and I'm happy to pick up other points later in the discussion. Again, thank you for having me, and looking forward to the questions.
Thank you very much, Peter, for again taking on what is a very, as you're noting, wide area of review. And so finally, I'd like to come to Ms. Otrida Kapona, who is currently serving as Zambia's antimicrobial resistance national focal point and has seen the successful completion and launch of Zambia's first national action plan on antimicrobial resistance. She is a public health laboratory scientist and works with the National Public Health Institute of Zambia with a focus on AMR surveillance, public health laboratory system strengthening, and laboratory diagnosis of infectious diseases. She also consults part-time for ReAct Africa. Ms. Kapona will provide her views on ensuring sustainable access to new antibiotics or to promote access without excess. Otrida, over to you.
Thank you very much, and hello, everyone. Allow me to first recognize the input that went into the research and putting this report together. I'll be providing a perspective from low middle income country. And I think, like Viviana rightly said, ultimately our goal is to ensure access. Now, even before looking at new antibiotics, access to most essential antibiotics is already a chronic disease in low middle income countries. Our health systems are weak, confidence levels are low, and the dependency of importation is over 90% for antibiotics and other molecules. Low middle income countries also have to deal with substandard and falsified antibiotics that again take advantage of the high prevalence of infectious diseases and weak health systems. Now, generally, governments have a mandate to provide affordable healthcare to its people. While most try, this has been a major challenge for most. Let me take an example of African countries. Despite the Abuja Declaration of April 2001, at which Africa Union member countries pledged to set a target of allocating at least up to 15% of their annual budget to improve the health sector, as at 2018, only 2 countries had lived up to that commitment. This includes other regional and global commitments focusing on health system strengthening. As a result, health systems remain weak, failing to meet challenges of the day. Now, to address the challenge of access in low middle income countries, there is need to take a multifaceted approach, just like addressing AMR in general, a systems issue. There's need for us to understand the different pillars that make up our healthcare systems, the drivers, the weaknesses, and how those weaknesses affects access to antimicrobials. Delineate and acknowledge the unique challenges that are specific to low middle income countries, such as infectious diseases, poverty, weak healthcare systems, lack of financial resources, as well as the current practices and the status of the pharmaceutical supply chain and the bottlenecks that have to do with pre-registration, qualification, manufacturing, distribution. Some of these processes are lengthy in some countries, and sometimes they will take up to 5 years. Now, contrary to popular belief, access to critical antimicrobials or antibiotics remains a major challenge and not excess. Having documented evidence that people can easily access antibiotics off the counter without a prescription does not necessarily mean excess. There are few molecules, of course, that we have in excess, but most of the critical ones that are needed to manage most diseases are not readily available. In most cases, up to 50% of medications that are on the essential medicines list may be stocked out. And this leads to reliance on very few molecules that are available by clinicians. Now, the report makes, I noted 3 major recommendations that were made. The first one was about strengthening healthcare systems globally. I took the liberty of rephrasing the recommendation a bit to read strengthening healthcare systems globally, most especially in low middle income countries, to include and not to provide, but to include financing options. There's need to provide market entry incentives that allow for discovery, manufacture, and registration of new molecules. We are agreed that strengthening healthcare systems to manage current antibiotics and novel ones cannot be overemphasized. One of the challenges that we have with sustainable action is that there are very few manufacturing companies in Africa, in the African region, that manufacture antibiotics, mostly due to pre-qualification and the stringent GMP requirements, which are both economically and financially intense. There is therefore a strong need to support local manufacturing to mitigate the challenges of access and affordability. And again, looking at the different challenges that low middle income countries face. There's need to spur innovation and support small biotech companies in the region. Now, the cost of manufacturing is prohibitive globally, and antibiotics do not generate as much profit as other therapeutics, such as those for cancer and all. Therefore, economic incentive is in a competitive market environment means that companies will generally produce products or medicines that ensure huge profitability. Deliberate efforts by government, funding institutions and charities should be made to incentivize the creation of small biotech companies and SMEs that will focus on innovation and R&D for new antibiotics. These would include universities and research institutions. An example we can look at is the way the US financed the creation and encouraged the creation of biotech hubs in genetics and other areas that then provided incentives for research, for biotech research companies. The second one was support civil society efforts to develop human resource capacity and structures. I couldn't agree more. CSO's involvement in addressing sustainable access is critical, and leveraging on their granular efforts and understanding they have for the communities. Some can be used as instruments for distribution and access to some of these antibiotics rather. An example I can give is the role that the Churches Association of Zambia has played in ensuring access to antiretrovirals in most remote parts of our country. The third recommendation is establishing a global WHO task force for introduction of new antibiotics. If we decide to go that way, like rightly said in the introduction, there is need for this task force to first look at what is currently obtaining in the ground. Because if we don't address the challenges and the bottlenecks that we have to with regards to access, even if we introduce new antibiotics, we're still going to have the same challenges, and countries and populations will still not be able to access the new antibiotics. There's also need to ensure that there's adequate expert representation, again, like rightly put, from the global south, so that we have a better understanding of the challenges that low middle income countries face, as opposed to have a task force that is mostly more, whose composition is more Eurocentric and American-centric. There's need to advocate for funding of universities in local research, as well as advocating for a regional funding pool. Maybe identifying regional institutions such as the Africa Development Bank that can be leveraged to power investment and research and development. There's need to facilitate actualization of initiatives. There are certain things that we have been talking about year in, year out that haven't been actualized. I think it would be important that we advocate for and facilitate for actualization of initiatives such as the food procurement, as well as harmonization of laws in the African setting that facilitate for registration and regulation of old and new antibiotics. Like they say, we need to look in the past and the present to better inform the future. If we decide to go otherwise, I still believe that we have adequate structures within the global governance and WHO that can adequately address these functions and where these functions can be anchored. Thank you very much.
Thank you very much, Otrita. That was fantastic. And thank you again to all of the panelists for your excellent interventions. So we'll now switch to the panel discussion, and we'll try to get through as many of the questions as we've received as possible. We will go a little bit over time, recognize some people will have to jump off, but since we started a bit late, just so we can try to get through all of the questions. For the panelists, just if you can offer short interventions, I will direct each question to one person, but then if others want to jump in, just raise your hand, don't bother with the electronic hand. And I'll come to you also before we go on to the subsequent question. So the first question comes from Oliver Williams from the Wellcome Trust. And I'll throw this over to Viviana first. So his question is, firstly, I wanted to thank you for the excellent report, which widens the discussion on antibiotic research and development, stewardship, and access. My question relates to the numerous recommendations that call for greater political and financial action from governments. Against the backdrop of COVID-19 and the huge resources that have been mobilized already, how difficult is it likely to be to successfully inspire governments to take bold action? And what, as stakeholders interested in antibiotic research and development and access, do we need to do collectively to achieve this? And actually, I apologize. Let me throw that actually first to Monica. So I apologize. I'm sort of just caught you off guard. I'm just rethinking that. But do you want me to repeat the question, Monica, or is that okay?
No, I think I picked up the question on the chat. So no, I think it's a fair question. You know, governments are pretty saturated at the moment. You know, midway through a pandemic that seems to be becoming endemic. So I think I do think that's a fair point, but one has to take a longer term view on this. And if one takes a kind of glass half full perspective, I think this is also an opportunity to raise the issue about preparedness, you know, in the longer term. And if we do want to prepare for future health, public health challenges and public health threats, then one does need to take, I think, the kind of actions, many of which have been presented in this report. So yes, if I go today and say, can you do all of these things, then you're probably going to get a glazed look, but I don't think that's necessarily going to apply, you know, 6 or 12 months down the line. I think it's important that we therefore sustain, I think, some, you know, advocacy in the context of how things are evolving with COVID-19. You know, as GARPI, we published a report on COVID-19 and pandemic preparedness and how this relates to AMR. And I think we do believe that there's an opportunity to influence governments to think differently, to act differently, and to be much more creative. And I agree that we need new solutions to solve this problem. And I think we also need collaboration across different sectors. It's not all going to come from governments, but you know, that collaboration between sectors are off. The tone of that is often set by policies that government make and the kind of resources governments put on the table, and we need to recognize that. I will end by saying one thing, which is, you know, I think the differences here is that we also need to be approaching a broader range of countries and not, you know, the kind of usual donors in global health. Global health has to change, and this kind of subsidized model, I think, is yesterday's model. I think we need a model that includes a broad range of countries, include much more stakeholder and ownership between these countries, but I think a broader range of countries need to put money on the table as well. Of course, based on resources and capacity, but that in itself is what gives one a greater degree of ownership on this issue.
Thank you, Monica. Anyone want to jump in, either responding to Monica or to the question itself, just before moving on to the next? Viviana.
No,
still going to get you.
Yeah, just a one-liner on that. I think, I mean, if we really want to mobilize more governance to give finance, in particular from low and middle income countries, there has to be a clear value equation of what their financing is going to bring in. So not only a promise of eventual access, but in the design itself of the solutions, how, for example, as Ostrita was saying, how can the research institutes, you know, also be provided with capacity? How can they be part of that process and not simply as, well, you know, give the money, we'll figure out the solutions, but then come on top to help, you know, a broader fund. So I think we failed in the past of explaining to some key governments how they could actually, you know, find value in participating in the system. So that's why it's so important to have this alternative approach.
Thank you. You know, Peter, there is a pandemic R&D treaty that is being discussed that may or may not include AMR. What's your sentiment in terms of whether or not that actually could play a role in mobilizing resources, and what are the risks?
Yeah, that's a very good question. We are, of course, at the very beginning of this journey of an pandemic preparedness treaty under the WHO Constitution. Many of you have probably read the editorial that was signed by many heads of states and also our Director General, Dr. Tedros, And we do expect that the mandate for such negotiations is going to be discussed at the upcoming World Health Assembly. And of course, the mandate is going to give us the scope of the negotiations. And it's clear it's going to pick up what we've seen, in this pandemic, where we do need actually more global rules. I do personally believe that antimicrobial resistance should be part of it, because it is linked. I mean, we call it a silent pandemic. We shouldn't waste this opportunity to actually have a comprehensive approach, instead of only focusing on what in WHO we call the blueprint pathogens with pandemic potential. Having said that, to the extent, one big piece in these discussions will be access to products. And as Monica said, taking the experience from the COVAX model, taking the experience from HIV, and what should be how should we regulate this in a global treaty? I think that is something where it won't be easy to find an agreement, but I think it's a great opportunity. It is, as some people say, never waste a good crisis. If this crisis is actually bringing us to go a step forward in global public health and have a more rules-based global health model, I think that would be great.
Thanks. I'm going to move on to the next question, which is from Kevin Outerson, who's the Executive Director of Corbex. I'm going to start this one with Hella. In the report, you talk about subscription mechanisms. The UK, so Kevin's question is, the UK antibiotic pilot has chosen 2 innovative antibiotics for a fully delinked subscription model. Is this a model for other high-income countries? And perhaps you want to mention a bit about what that model is, and also as to whether or not this is an appropriate model for other high-income countries, and actually maybe for other countries in general. Helen.
So in subscription models, so they're the way forward. For those that don't know what a subscription model is, it's perhaps easiest to think about Netflix and think about a government sort of paying up a subscription fee in an agreement with a company that has a sort of a maximum level of what that fee can be. And then they get access to all the drugs that they need, and thereby you sort of remove the link to oversell, because you're kind of just providing what is needed, really. Is this I think it's clear it's not a solution for the world. And I think the bigger points on this actually come back to a really great point that Viviana made earlier on, where she talked about, of course we need to be pragmatic, but at the same time, we also need to be highly ambitious. And I do think that there is some point where, the pragmatic solutions take over and we forget to become, or we forget to be highly ambitious. And I see a divide where, we're advancing a model, or there's attempts to advance a model that really, if we're looking at it, is only applicable and suitable for high income countries. And we're kicking the can down the road of how are we going to solve these issues? How are we going to do the introduction into low and middle income countries? And not really get into that question. So it's, yes, I can see that there is perhaps a pragmatic way of testing this out. Let's see once the pilot project is done and we have some results from it to sort of judge it better on whether it's worked or not. But I do think that there are some critical shortcomings in that model that takes us perhaps in a direction that doesn't lead us to the global solutions and appropriate solutions for other countries that don't have the infrastructure and the money available that high-income countries do.
I do want to redirect some questions, but first, other panelists have either a response to Kevin's original question or to what Hella has just said. Monica.
Yeah, I think there can be more than one model obviously put in for payment or reimbursement, or whatever one wants to call it. What I do think is something we should avoid is a kind of, a global fund Gavi model. I'm not disrespecting that, because I think that has done a lot of good in terms of responding to, infectious diseases, HIV, TB, malaria. But I do think that this kind of subsidized model is not an answer at all. And it's really the opposite direction of where we should be going. And I do think this is what has disempowered low middle income countries to some degree from discussions in the equation. I do think that obviously there have to be models that are adapted for different countries, and different countries may have preferences. But I think Viviana said it herself earlier that, you know, if countries have to see what they're getting, and then you can discuss with them, you know, how they can pay for that, if I can put it this way. But if that's not clear, and the drugs are not even being registered in these countries, let alone, you know, being developed with a very small data package and all this, they put all their concerns on the table. And this is not just lower middle income countries. I quoted the report that came up from the EU JAMRAI for a specific reason, to say this is coming also from high income countries. But having said that, we need some mechanism that will work. And I think this is an interesting mechanism that's worth looking at, but with all the caveats some of the caveats that I mentioned. And I absolutely agree that we have to recenter the discussion around access so that countries understand what the benefit is. Then we can have a discussion on what countries can pay, instead of the other way around.
And again, just one additional follow-up on this. Otrida, I apologize for putting on the spot. When you're looking at the possibility of subscription mechanisms, whether it's a UK-based one or sort of one that would be more, let's say, aligned or appropriate for use in Zambia or for countries in a similar context, what is your opinion? What would be the right approach, or what is your opinion of subscription models that have emerged, especially in Europe, if at all?
I don't know how to put this, but I think that for the subscription models that have been highlighted, I don't know, I can't state for a fact which one would be workable for our country, because of the differences, the differences in the way our healthcare systems are structured. There are possibilities of adopting or adapting, but I guess would have to look at what would really be workable for the country. Unfortunately, I didn't go into detail to look at what really is proposed, but I think that there's a possibility to look at what is being presented and then see how best that can be adapted. But we need to understand that there's a difference between the way systems are structured in high-income countries and the way systems are structured in low-income countries. And that is a major factor when it comes to deciding which way or which subscription models are workable for which country and which region. I hope I have answered your question.
No, that's great. And let me stay with you for a different question, which is coming from Maria Teresa Bejarano, and I apologize, I don't have her institutional affiliation. As we know, there's been a lot of discussion about increasing the capacity of low middle income countries to produce vaccines and medicines. And this has been propelled, of course, by the challenges that we've seen for access to COVID-19 vaccines, which some of our panelists also talked about. And so in what ways could the lack of access to good quality antibiotics, as well as the challenges with falsified and substandard antibiotics in low middle income countries, be addressed with local production?
I think first and foremost, if we have local production, we will look at what the needs are, and these would be informed by evidence generated locally or within the region. And then I want to believe that each country has systems in place to ensure that medicines, whether produced locally or imported, meet the set standards of the quality, the efficacy, and all that. So if we built capacity, local capacity to have certain antibiotics manufactured locally, I think that, and then we strengthened our regulatory mechanisms and local systems that are mandated to look into the issues of the quality and the efficacy of antibiotics. That way will ensure that we have taken care of the issues of substandard medications. Now, maybe let me mention that I don't believe that the solution to this particular problem is one-sided. There are different systems that countries need to strengthen, and that has to be done alongside each other if the system is to perfectly work holistically, because addressing one of it doesn't take care of the problem at all. So we can say we manufacture antibiotics locally, but there's also the issues of regulation, regulating and monitoring, whether it's post-marketing surveillance or pharmacovigilance, or the quality checks that are done before a product is put on the market. Those systems are weak in most countries, and those need to be strengthened as well. So there's need to approach it from different angles and ensure that we are looking at the different pillars of the healthcare system individually and looking at where the weaknesses are and strengthening them together. Because for as long as we are looking at it from one point of view, all the efforts that we put in remain inadequate. Additionally, I think it will also build a certain capacity and create and partly address the gaps that we are seeing. I would tell you that some of the people that you will find dealing with in substandard medications, it's not because they want to, but some of them, that's the option they have to survive. And so if we provide an option for them as we try to take away what they have, then we're addressing the issue, because for as long as we are not providing an option, we don't expect that they will let go of what they currently have to survive. So I think that would partly address the issues of substandard medications, but we can't do it as a standalone intervention. It has to be complemented by other strategies, such as strengthening the other regulatory mechanisms with regards checking quality of medications, but also the post-marketing surveillance and pharmacovigilance that are mandated to most medicines regulatory authorities or agencies in the different countries.
Thanks so much. And I'm going to keep moving to other questions. I recognize we're on time, of course, for our attendees. Our panelists have agreed to stay on for 10 more minutes. So we're going to kind of try to run through the rest of the questions. So the next one, this is for you, Dr. Torrens-Bakker. And this is from Champo Morea. Again, I don't have an institutional affiliation. So setting priorities is currently based on the most urgent pathogens, which in my understanding are those that have developed resistance to one drug or for which there is multi-drug resistance. If the current focus globally is only on the most urgent needs, won't this turn attention away from emerging and re-emerging pathogens? So if you can, I don't know if you need any clarification or if that was clear.
Yeah, so the priority pathogen list also included one element of somehow projecting the expectations in the future. And for bacteria, you can do it to a certain extent. It's very different with viruses. But with bacteria, you can somehow see trends, at least for a few years ahead. So that's the reason why it's still valid. What doesn't mean that we don't need to update it. But so far it's still valid. And I think we should really leave this resistance mechanism problem, because resistance mechanisms emerge. It's not so much the pathogen, but it's the resistance mechanism that can emerge rather quickly. And as long as we focus on resistance mechanisms, we will be in a big problem. Usually after a very short time, a new antibiotic comes to the market. And I mean a new antibiotic that just fixed certain resistance mechanisms, then will run into a problem very soon. So to my opinion, we really need to focus on new classes that don't have this cross resistance, because we cannot fix this single resistance mechanisms. It costs too much money and too much time, too many resources, and we should really focus on antibiotics with no pre-existing resistance mechanism, no pre-existing cross resistance. And then we wouldn't have this problem.
Thank you. Does anyone want to add anything to Ursula's response? Okay, I'm going to try to squeeze in one more question, and if after that, maybe one more. This one comes from a colleague at Médecins Sans Frontières, Pieter Jan van Egermont. He asks that, and we've talked about in a couple of the presentations on the need for a global intellectual property pooling mechanism. Should this be voluntary or compulsory? We've tried for a voluntary mechanism with during the COVID-19 pandemic with what's known as the COVID-19 Technology Access Pool. And as he notes, it's failed, or until recently, it has been empty. Now, the political leverage for a compulsory mechanism is probably non-existent. So is a voluntary mechanism the only option? And does anyone have any ideas on how to go about establishing such a mechanism, whether or not it's voluntary or compulsory? And I'll start with Vivian on this.
Thanks, Rohit. I mean, I think the role of intellectual property has to do with what's the kind of system that we've set up. So if, again, we're talking about the market-based pharma-centric system, of course, there's a strong incentive to retain IP rights, because that's driven then with more of control, both for the product and then in setting up conditions for access in the system. So even if we have, for example, a subscription-based model that drives payments instead of sales, the IP question might still be there as a way to retain being that single developer for that product. So we really have to understand what's the ecosystem. If we have an ecosystem where we say, well, we can work in a different way with different sorts of stakeholders in the R&D chain, we can have potentially a different way to do clinical trials, and then potentially once we have the new antibiotics, a different way to produce them, including options of seeing where we can have, for example, government facilities and other models, then the IP question changes. It is important, though, to understand for each of those stakeholders, what is the IP question? What is the interest in retaining IP rights, for example, to adequately address them? So even on the academic side, understand why they're seeking IP incentives. That gives us idea as well of what are the options for then giving alternative incentives. So there is in the report the idea of, for example, of a large buyout. I think that would be important if we do see that, so there's sort of that single developer with the IP. But in other situations, we really have to be more specific. And I think there are examples from COVID situation, but there's also quite different particularities in the fact of who actually develop vaccines. So I think there clearly is more that there is a reluctance, of course, to share IP. Because there's such profits to be made in this area for the moment. And so it's more of reluctance to give away the rights. So I think there's a role for government to just step in and say, we need to discipline them here if they don't fill with the conditions of the adequate social contract that the IP system is supposed to have.
And I'm about to hand over to Helle for wrapping up, but Monica, I'm going to squeeze in a very quick question. When you're thinking about this, and GARD-P has developed a not-for-profit model, how do you see that then as an issue, and how would you manage it, and what type of system are you trying to establish really with the not-for-profit model? How does it address these challenges?
Yeah, so I was going to request that you back the question to Peter on IP, but I'm happy to say what we do in terms of our approach. And look, we are a small organization which is very young, so I will emphasize that we have limitations on what we do. But I think what we try to do is we genuinely try to work in a collaborative partnership with companies, and we take the approach that, look, we'll bring in something, you're bringing in something, including the asset, and how can we basically meet each other's objectives. But I think the crux of it, there's two things, there's two key things. First of all is to have an open and honest discussion on what their objectives are and what our objectives are, and see where there's significant overlap. And often there is actually significant overlap, which is helpful. And then where there are specific things that we are requiring that would not be the company's priorities. And that's where we will include a range of things in the discussion, including potentially, licensing. And as you well know, we have included that in 2 agreements that we've made with companies. And I think in those are biotech companies, they're not big pharma companies. And those agreements are not framed as corporate social responsibility agreements. And I think that is a good and productive model to work on, because everyone knows where they're standing, everyone knows what each other wants. Now, the caveat on that from our side, of course, is that becomes more successful if you have more resources behind you. So I'm not making a plug for GARDP, but it's obvious. If you have more resources, you can negotiate more. And I think the second condition is that, and this is an important one, you have to be able to walk away. So if you can't make an agreement, it's fine. You don't often have the same interests, and maybe there are other alternatives one can look at, and then that one has to accept that. But you certainly don't go down the approach of making an agreement at any cost. And I certainly think that some R&D funders out there that have a lot more power and money than GARDP can certainly do much more than what GARDP can do. So I do think that that's something that we do need to consider if one is considering a kind of a voluntary framework, if that's the right way of saying it. Although for me, I think what public funders have to do, and this is really important, they have to come in with the perception that they come in as a public investor, as an investor. And then I think you can have the scope to discuss the rules and conditions. And when you have many different investors, public investors together, that's where you start developing norms, even if they're soft norms. So I think one has to maybe think of the extension of there, and rather than critiquing companies, I would always say, critique the one who's putting the money on the table and not asking for any conditions, because that's to me the where you're really losing out on the public financing. And I do of course agree that there is of course a social contract. I actually, in my experience, most companies I've worked with actually really do understand that and actually they partner with organizations like GARDP because they recognize that. But the concept of the social contract is important, and I think it has to be called out when that's gone beyond the bounds.
Thank you so much. And we are almost at time. I want to come back to Helle, who launched this discussion with the presentation of the reports, to come back with some final remarks. Always hard to do, but over to you, Helle.
Thanks, Rohit. So first of all, I obviously want to thank everyone for taking the time to join us today, and especially our speakers. I think you've really helped us achieve the first and foremost goal, which was to sort of let's unpack this discussion a little bit more and go well beyond and try to put all the details and all the nuances and the difficulties much more into the light, so that we can move away from something that we believe has been too narrowly focused globally in the debate there. And it's really difficult to come in and wrap up with so many great things that have been said. So I probably won't give that even an attempt, other than to say that this is everything that I hoped it would be. And I'm really hoping that this is a discussion that continues beyond this debate that we had today. I encourage both the speakers, but obviously also everyone that took the time to sit and listen in, to read the report. If you have the time, do send feedback, do send your thoughts, do find ways to critique it, to praise it, to develop it, to build on it, so that we can sort of continue a conversation that builds on all these different lessons that have been brought out here today. So with that, I'll wrap up and thank you again for joining, and hopefully I'll hope for another opportunity to discuss all these issues soon again. Thank you.
Thank you, everyone. And thank you again to the speakers and to the audience. And I hope everyone stays healthy and well. Bye.
Bye-bye.
Bye.